Yes, the modern brain surgery, how big a hole is it? Is it a laparoscope? Where is there a normal place for the hole to occur in the skull? And is it healed over?
So, Jacob?
That's a fantastic question. I wish I could do a drawing. Paradoxically, the deeper a tumour is, the smaller the hole needs to be, because you can work through a small hole and use that as a bit of a fulcrum to engage your angles to resect the tumour. The more superficial the tumour is, the larger the hole needs to be. Now, I showed you the skull. That was a trepanned skull, but of course, in modern neurosurgery, we take a disc of skull off at the beginning of the operation, and then we put it back on when we're finished, and we fix it in place with titanium plates or titanium rivets. Now, you've probably seen these old pictures of people with half their head shaved in preparation for surgery. Jonathan, I'll speak for as well. We don't do that in this day and age. We try to do minimal shaves. We try to make the incisions as small as possible. So I can't give you a blanket answer as to how big the incisions and the holes in the skull are, but for a deep tumour, think something along the lines of a 20 to 50 cent piece.
Just to add to that, I think the biggest change there is with the stereotaxy, which is where we load the scans onto the computer, and that can sort of tell us where we are on the scalp or the skull relative to where the tumour is. So we don't need to as often do sort of a big operation where we have to kind of allow for a bit of margin for error there.
Okay.
One more
This-
question.
Yes, Ross?
The shunt. My son has a shunt, which is apparently programmable. When he has an MRI, the programming in the shunt is wiped out, so it has to be reprogrammed. How does that occur?
Okay, so Jacob?
Shunts, just for everybody in the room, a shunt is an operation that diverts the normal brain fluid from the brain down to the tummy. We all produce about half a litre of brain fluid each day. When that brain fluid gets obstructed or the absorption gets impaired, we have to divert the fluid so the brain pressure doesn't go up. There are a number of ways in which we perform shunts. There are a number of types of different shunt valves that regulate the drainage of the fluid from the brain down into the belly. 15, 20 years ago, there were only fixed pressure valves that had one pressure, and sometimes that pressure was wrong for a particular patient, and we'd have to operate to change the pressure of the valve. In modern shunt surgery, we generally put in programmable shunts where we can use a device to help program the pressure at which the shunt drains. Now, what you're talking about is a shunt that sadly changes its pressure in a very strong magnetic field that you find in an MRI. Some of the more modern types of programmable shunt don't have that downside, so that one can have an MRI without needing a shunt to be reprogrammed. Reprogramming is generally fairly straightforward. We just use either a magnet or an electronic machine with a magnet in it just to dial the pressure up and down on the shunt. So it's not done intrusively, it's not done through opening the skin at all. It's just done through a very localized magnetic field just over the shunt itself. Does that make sense?
Thank you.
This next question, I think probably will need a comment from both surgery and radiation. So the question is, can radiotherapy be first-line treatment for patients who opt not to have surgery, irrespective of biopsy results, benign or malignant tumours? So I'll start with Sue.
It's a great question. I guess the short answer would be that is definitely not our preference, because as you've heard this morning, there's such a range of both malignant and benign brain tumours, and even within each category there are different subtypes and different grades. So the treatment and the sequencing, radiation, the dose, the area that we need to treat is very different depending on the actual tissue. And I guess as much tissue as the pathologist can receive will really help us determine the treatment. So it is I can't think of a case where we've done that, because I just think there's too much uncertainty in the treatment, and this is very significant treatment for patients, and we would not commit them to something without knowing what the exact diagnosis is.
Another issue with that is that sometimes what looks exactly like a tumour radiologically is not a tumour, so it's something else. So that's why we really do need tissue if you're going to be treated with radiotherapy or chemotherapy.
So in many different cancer sites, sometimes there's a biopsy first and then there's a decision making, but often we get a lot of clues from the radiology and the pictures, and usually people like Jonathan and Jacob, their first approach is not just a biopsy, they will actually do the definitive sort of resection at the same time. So I'll pass over to Jacob.
2 points, or 3 points really. One is diagnosis. I think that surgery is often necessary, as both Michael and Sue have said. Second point is one of the potential aims of surgery is cytoreduction. So chemotherapy can often reduce the size of a tumour, even attack 99%. Radiation likewise. But if I as a surgeon can remove 98% of a tumour, leaving only a small remnant, that makes the radiotherapy and the chemotherapy more effective against that small remnant. Okay? But the third point I'll make, which Sue was about to point out, is that there are some tumours in which we may not want to do any surgery or any biopsy, particularly brainstem gliomas in children. Now, even in that particular subset of tumours where a few years ago we just give radiation without any biopsy at all, now we're starting to biopsy these tumours just to get more of a molecular profile to guide treatment in the future. So I think in this day and age, treating tumours with radiation alone, generally we try not to go down that path.
Okay. Thanks. Jonathan, did you want to add anything to that about...
I was just going to make the point Jacob did at the end, that there are certainly some tumours, and we've been talking mostly about glioma, but some meningiomas or other skull-based tumours like vestibular schwannoma or acoustic neuroma, that it may be that we can make the diagnosis radiologically and see how they respond to focused radiation.
Okay. I've got some other questions. This one's directed to Sue, to our radiation oncologist. And that's, what is the average lifespan after diagnosis for a grade 2 oligodendroglioma? So, well, it's probably, I think Helen's just as able to answer that. So,
look, it's a difficult question to answer. Some of these tumours have, when they're in a young person causing no problems in a reasonable area and they've been resected, we may sit back and watch them for 20 years and do absolutely nothing. Whereas some of them might start to progress quite quickly after they've had surgery or radiotherapy, etc., etc. So there's an enormous range. I think at present for a grade 2, we're probably looking at 10, 15, 20 years. But in some of them might have a bleed. These oligos tend to bleed more than other kinds of brain tumours. So people could get deficits or problems. But it is just incredibly variable, and a decision to treat now or to treat later, or how to watch, how to monitor, is really up for grabs. We've discovered more molecular genetics that is helping us put these into the right kind of boxes, and may actually give us some different treatment protocols in the not too distant future. So saying, it's 10, 15 years today may be absolutely irrelevant in 2 years' time.
So I might actually hand it back to Michael quickly, and then I'll go to you, Jacob. So in the past, Michael and his colleagues would look down at their microscope and say, look, this looks like an oligo. But perhaps, Michael, you could talk about the recent changes in the classification and how the definition for oligodendrogliomas has got a lot more stricter, I guess.
Okay, so initially to just follow up on what Helen was saying, so while we... on average, you can give a vague prediction about how long a tumour is going to take to grow. Sometimes, even with all the molecular information we know, we just can't predict it. It'll look just like an oligodendroglioma that might grow very, very slowly for 10, 20 years. And you might have a tumour that looks exactly the same, but then it recurs very rapidly. And currently, we don't know why that happens. So in terms of the diagnosis of oligodendroglioma, or brain tumours in general, historically, tumours were diagnosed by looking down the microscope, looking at the morphology of stained sections of the tumour, and then comparing that to what the normal cells looked like. So an astrocytoma looked sort of like an astrocyte. An oligodendroglioma looked like an oligodendrocyte, which is another one of the glial cells in the brain. However, it was found that the morphology is a readout of what's happening in the genetics. Now, it was found that the morphology didn't really predict the genetics or the molecular background of the tumour, so that if you had a tumour that looked like an oligodendroglioma, and that was characterised by having uniform round nuclei of the cell, often a halo around it like a poached or a fried egg, and a particular pattern of blood vessels in the tumour, while if you saw that, that was, and all those features were there, that was pretty typical of an oligodendroglioma. Sometimes you'd have a few of those features, like you might have the blood vessels, but you wouldn't have all the other features. And some people would call those oligodendrogliomas, other people wouldn't. And then when you look at these cases molecularly, you find that they're a huge mixture, which means that you can't predict what's going to happen. You can't really design a clinical trial because you're looking at a hodgepodge of lots of different tumours. So one of the things in the most recent WHO classification of brain tumours, and that's a book which allows pathologists all over the world to give a uniform classification. So what I call an oligodendroglioma is the same as what somebody in Japan calls an oligodendroglioma. And so for some tumours in the most recent iteration of this book, which was in 2016, they've introduced molecular characteristics which are required for the diagnosis. So an oligodendroglioma requires the molecular finding of loss of parts of two of the chromosomes, chromosome 1 and chromosome 19, and it requires the presence of a mutation in the gene, the isocitrate dehydrogenase gene, independent of what the morphology looks like. So that means we can all diagnose oligodendrogliomas based on the molecular findings, and that molecular group behaves much more uniformly than what we used to call an oligodendroglioma based on morphology. So for a number of tumours, a combination of morphology and the molecular findings are now required to classify them, and that allows us to make, as was said, we put tumours into boxes. This makes the box much more uniform. Now, if we've got a box with a uniform contents, we can have treatment that just treats the tumours in that particular box. We're better at predicting what's going to happen to those tumours than before. So the addition of molecular phenotyping is really important for tumours, and that will continue for other tumours in the future.
Yeah, so it used to be that we'd say, this has got a bit of fried egg appearance, so we think it's more oligo. This looks more like, the star appearance.
And so if you wanted a second opinion, you could sort of predict, based on who you were going to send it to, as to what they would call it. Would they call it an oligodendroglioma or an astrocytoma? And following on from that, there used to be a tumour group called oligoastrocytoma, which had some features of oligo and some features of astro. That tumour now doesn't exist, because if you look at those tumours that had morphological features down the microscope of either an astrocytoma, and astrocytes have sort of cell processes, or an oligodendroglioma, if you look at those molecularly, they either separate into things that are molecularly an astrocytoma or things that are molecularly an oligodendroglioma. So you don't have this mixed thing. So that's clarified a lot of the diagnoses as well. But the diagnoses change, and it wasn't wrong to call a thing an oligodendroglioma 5-10 years ago. So that's why it's also difficult to compare results of previous studies from 10 years ago when they, for instance, looked at the prognosis of oligodendrogliomas, because we know that what they called oligodendrogliomas are now a mixture of things that aren't all oligodendrogliomas. So it's difficult to extend the previous results to the present findings.
Just before I hand over to Jacob, just all our speakers really had to sort of to keep to time, so we didn't go into detail about the different grades of tumours. But essentially, gliomas come grade 1, 2, 3 and 4. Grade 1, we adult doctors don't often see. It's mostly a paediatric diagnosis, though not always. From grade 2 to grade 3, it can be either from the oligodendroglioma family or the astrocytoma family. And then there's the grade 4, which is the glioblastoma, which I think now you say is purely most astrocytomas. So, well, I mean,
It's also changed a lot because I mentioned IDH mutations. Now, the grading system is a purely morphological grading on the presence of things like evidence of proliferation, like mitoses, the cells are dividing, evidence that there are new blood vessels in the tumour or that there's necrosis. Now, the molecular findings impact the grading. Well, currently that isn't incorporated into the grading system, but it will be probably in the not too distant future, so that IDH mutant tumours seem to behave completely differently to IDH wild type tumours. So even with a grade 2 and a grade 3 tumour, if it's got this IDH mutant, in some studies, even if we call it grade 3, which should behave worse than grade 2, they don't. They behave the same. So in the future, they're probably going to be changing the way that these tumours are grading. So it's a sort of a moving target.
Jacob, did you wanted to add something there?
I'm just going to add one very simple message. None of us like talking about average survival of a particular tumour because it's rubbish. We're looking at big populations and trying to get some statistical bland mean out of this big population group. I much rather look at the individual in front of me because survival is individualised. So if I say the average survival for X type of tumour is 5 years, the only message that somebody is going to hear during a half an hour of speaking is, I will only be alive for 5 years. Okay? Rubbish. Survival is individual. Full stop. Okay?
So, so average survival is useful for governments and for clinical trials to try and work out whether we're actually making improvements. But as Jacob said, none of us ever predict a survival for an individual patient in front of us. It's very dangerous practice, and we're wrong more often than we're right. So, Kerrie, I've got a couple of questions for you. There's a very long question, and it's very individual, so I'm just going to pick out bits from it. So Kerrie's a world expert on MGMT. So this is a question actually about a grade 2 oligodendroglioma patient, but one of the questions within it is chemosensitivity to Temidol is determined by MGMT expression. Why is this not tested in Australia despite this? So Kerrie, why don't you explain to the group what MGMT is and what some of the controversies about it are?
Okay. Shush. Right. So MGMT is a DNA repair gene. And so basically in some tumours it's switched on and in some tumours it's switched off. So if it's switched on, it means MGMT unmethylated. And that means that the DNA repair protein actually repairs a lot of the damage done by the chemotherapy.
And the radiation.
And the radiation. So MGMT methylated means that gene's switched off and you have a better prognosis, and it's predicted to be better with temozolomide treatment. So that's what MGMT is all about. And so we do test this in GBM patients, and it is actually available around Australia. Well, you can find a lab that will do it. We don't tend to do it in lower grade tumours, so oligos and astros, because the majority of the time an oligo or an astro lower grade is actually methylated naturally. And we don't know what that means prognostically with the patient. But we do know with the studies in GBM.
So GBM is another an abbreviation for glioblastoma, which is the grade 4 tumour.
Yeah, so we do know in GBM, if you're MGMT methylated, the patient's prognosis tends to be much better than MGMT unmethylated.
But that said, we've all seen unmethylated patients who do
tends.
who do brilliantly. So it's certainly not a, it's not a hard rule, but it is very useful. Now, and MGMT is tested in different ways around the world. So
yeah, and that's one of the controversies of MGMT methylation is that you can be tested in one lab and you may be methylated, and then you send your sample somewhere else and it could be unmethylated. It's a very, very sensitive test. And unfortunately, it's not something that's switched on or off. We have levels. So you could be highly methylated or you could be slightly methylated. We actually clinically don't know what that means yet. So we set our cut-offs based on big populations of patients and the trends with the prognostic relationship with that. And so typically it's around about 9%. So if you're MGMT methylated and you show a methylation reading of above 9%, that tends to be what we call it. Now, there are different methods for doing MGMT methylation testing and different equipment availability. Now, probably the worst test is MGMT immunohistochemistry. It's not reliable at all. The second worst test is MGMT PCR. Again, that's not a reliable test, but some labs in the world do it because it's cheap. The most robust test, and I'm being biased here, is actually pyrosequencing, and it's actually a specific instrument that a laboratory needs to purchase, and they're not frequent in pathology departments at all. So that's why the price is a little bit costly. And also too, I think Helen mentioned that when you get molecular testing done, it actually takes time. So, you know, unfortunately we know that you guys are waiting for the test to come back, but an MGMT test actually takes 4 days in the lab to do. And we can't take shortcuts on that test, so it actually does take a lot of time.
But it's a great question. And Pat Wheaton, who, this is something we'd love your group to campaign about. 1P19Q, which actually we need for diagnosis, is not paid for by the government yet. So and it's much cheaper than Avastin, and it really does. And so there's a whole lot of things. And MGMT is also useful, and these things are not yet standard and reimbursed. And it's the last thing when a patient's got bad news to also be asked to sort of, fork out some extra few $100s for this test and that test. Before I go to back to the room, just to keep up with the MGMT question. So Helen, we medical oncologists breathed a sigh of relief back in 2005, I think it was, when Temodal came onto the PBS, that they did not mention MGMT in the listing. We were very worried it was going to say it was only for patients with MGMT methylation, because we know that it does work in a percentage of patients who are unmethylated. Helen, how do you use the MGMT result, if at all, in your patients? Do you use it different for younger versus older patients to guide what you do when you stop clinical trials?
Number one, because we know from large statistics that patients with an unmethylated MGMT promoter may not do very well compared to patients with a methylated MGMT promoter. So there's some clinical trials that are designed for people with unmethylated MGMT promoters that vary from the standard garden variety treatment. So we will use that to screen patients to be eligible to go on trials and potentially try different drugs. The main use I find is that about a month after radiotherapy, some patients' whole brain seems to swell up, especially around the area that the radiotherapy's been given in. And they can get very symptomatic. When you take an MRI, it looks like the tumour's back with a vengeance. And there's some suggestions that if you've got a tumour that's very sensitive to radiotherapy and chemotherapy, they are more likely to swell than those that don't have are not as sensitive. So if we have someone with big lots of swelling at month +1 after radiotherapy, we may take a rain check, give them steroids, not be quite as worried about them as if they didn't have a methylated promoter. Certainly people that go on to Dr. Google, read, and then they come into the office and say, but I'm unmethylated and I'm going to do really badly. I keep reminding them, one of my patients who had AGBM and who was unmethylated, and it was before we even gave chemoradiotherapy together. We just gave radiotherapy followed by 6 months of chemo. And no one ever, we reviewed this woman's pathology about 5 times because no one believed the fact that she had an unmethylated GBM in a pretty bad location and it did not return for 9 years. So you can put a label on it and you can say, I'm unmethylated and oh dear, but it is certainly not black and white. And you can't just go into the doldrums if you don't have it. So we don't do it if we have an IDH mutation in the lower grade tumours because, as Kerrie said, we don't really know what the relevance is. And the MGMT gene is on a chromosome that you lose in high grade tumours but you don't in low grade tumours, and therefore the method for testing the lower grade tumours may be different. So just sending a lower grade oligo or astro along to your lab and saying, do an MGMT without considering how many chromosomes they've got may be completely irrelevant. So there's lots to learn about that and its significance for the future.
Yeah, and it's the higher grade tumours where the MGMT's been looked at, so we don't really know its importance in the lower grade tumours for the person that asked that question. Now, Sue spotted a hand up in the audience. Someone had a question?
Did you still have the question?
Okay, all right then. So, Kerrie, we've got a question. Someone's interested to know what you're studying and focusing your research on at the moment, and with a specific question about your interest in PARP inhibitors, and whether you're recruiting to any studies at the moment. So,
Yeah, that's a great question. What am I doing? We've actually refocused the lab quite extensively, and if everyone's welcome to come to the lab, because what I've trained the group to do is they don't do a lot of basic science anymore. What they're drilled into them is what they do at the bench has to make a difference in the patient. And so that's what our pipelines are all about, is drug discovery and implementation into the clinic. So we work with a lot of pharmaceutical companies and a lot of local companies, and what we do is we've got these models that we call patient-derived models, and what we've developed is from the patient's tumour is tumour cells that grow in a dish, and we've got tumour cells that grow in a mouse, so a surrogate. And what we do is then we take these new drugs and we use a panel of these patient models, and we try and work out who's going to respond and who's not going to respond to that drug. And then what we do is we do a small clinical trial in the mouse and actually show that this drug is working in this group of patients. And then what we're doing with the clinicians is we're working hand in hand with the clinicians to move these clinical trials forward. And so I'm involved in about 5 clinical trials right now, and we may be just doing MGMT testing for some of those trials, but we're actually running our own trials with immunotherapy and other combinations of a repurposed drug with temozolomide as well. So that's typically what we're doing in the lab.
I'll just make a comment on that. I think what Kerrie's talking about really highlights something that's very important in the world of brain tumours, which is collaboration. So first of all, we're here now with, experts from 5 different crafts sitting at the front of the room, because everyone's valuable in this. And obviously we can't, Kerrie can't do clinical trials directly because she doesn't work with patients, but clinicians can't do clinical trials without having laboratory support, or that's where many of the discoveries are made. So I think it's very important to recognise that, and obviously patients and the groups that have helped support today are a very important part of that collaboration. And I think because this is definitely something that we all need to work together with.
And it might be a good opportunity. It used to be a talk at this forum in its own right, but we try and mix it up, so it didn't get its own birth this year. But some years we talk about what clinical trials are and demystifying clinical trials. So just to let you know, you might hear about different things in the newspaper or on the television, but there's different types of clinical trials and they've got different chances of helping an individual. So so there's what we call preclinical studies, like Kerrie's mentioned, in the mice, in other animals, or perhaps even just in glass jars. So they're sort of in vitro, or what we call in vivo animal models. And there's phase 0, when we work out how to actually deliver a drug to a human. Phase 1 is sort of first in human, and sometimes phase 1 studies are come one, come all. So patients with lots of different cancers might be in a phase 1 study. And those are studies where the doses are really, really small initially. So those are studies for to work out the optimal dose to go into the next phase of studies, and also what are the side effects. So the old model used to be 3 patients. If there was no side effect, move up the dose. If there was a side effect, go back. If it's if there's a side effect, add another 3 patients, and if there's 2 side effects, you go back down to the lower dose. So it's very sort of strong rules about how you move up a dose. a phase 1 study has got a very small chance of helping an individual patient because it's not necessarily targeted to a particular tumour. But of course there are some exceptions. There have been some amazing phase 1 studies in recent years where melanoma patients have really benefited, or certain lung cancer patients, for example. So if people are wanting to participate, by all means, but you just got to realise not to have high expectations. A phase 2 study is a bigger study, and it's usually when there's been a signal from phase 1, hey, these 4 kidney cancer patients did really well, or these 6 brain tumour patients did well. So it's usually a study in the disease of interest, and it's a larger, it might be anything between 30 and 80 patients, it might be randomised, and so that's what we call an efficacy study. What's the response rate? And then phase 3, which you might have heard about, is sort of, I guess, the gold standard and what we call the highest level of evidence, where it's actually patients are randomised to standard treatment versus that new intervention or new question. And we really need phase 3 data to sort of show whether something's better than what we're already doing. And lots of different groups in lots of different diseases, not just cancer, have been caught out by jumping on board the bandwagon with just phase 2 data, and have come to, very, very famous sort of examples of that. So it's always the phase 3 data, which is the very important data, and often it's the standard arm ends up winning the day. There's something called phase 4, which is when a drug or an intervention's been around for a long time, and it might be testing the general population, so a less fit population, and long-term sort of side effects. So, and generally there's also evidence showing that patients that participate in clinical trials often do better than the average cancer patient, perhaps because of and that's including patients on the control arms. So there's so much sort of supervision and involvement of so many different people for clinical trials. So people shouldn't be nervous about clinical trials or worry about, I'm just a guinea pig. Clinical trials are really important for the next step. And many individual patients do benefit. We know that paediatric patients is about 80% or something participation in clinical trials, and they've got a much higher overall survival than the adult population. Before I move off, any particular question about designs of clinical trials before we go to our next draft of questions? Yes, over here. It's John, there's just a person in the audience with a question.
I was the person asking the question to you, Kerrie, about what you're up to at the moment and about recruitment. I heard you speak a couple of years ago and I got very excited about this precision treatment and the work. And the impression that I got back then that we're taking live or fresh tissue straight from a resection or a biopsy and doing this study in the lab and then trialling it back on the person who the tissue came from. Was my understanding correct?
That's correct.
And if so, how can anyone, that's what I meant, can you recruit? Can next time I have some fresh tissue, how would I, could I get involved with your study? Yeah. And how difficult is it? Do I have to have the surgery at Prince of Wales with Dr. Fairhall who does it there? Does that make sense?
Yeah, it does. I mean, precision medicine or personalised medicine is a really tough game. And the reason why it's tough is as you just alluded to, is where do you have your surgery? Because not everyone biobanks or takes fresh tumour and grows it. So you do have to be very specific of where you go for your operation. What we've done is a prospective cohort. And basically that was building our panels so that we could actually test drugs on those panels and have different tumour types in there. We also have a prospective individual program, and that's basically we've got funding for patients under the age of 40, because that's where the foundation was directing their money towards, was young patients. And what I found was that the timing is very, very precious. So from the time that we get the tumour, we have to race back to the lab, grow those cells, put them in the mouse, and this is a 24-hour turnaround, and get that tumour DNA out of the tumour and sent for sequencing. Now that's where our problem lied, was the bioinformaticians. They were slow. They wanted to sleep. God. And so basically what we were finding was the pipeline was too long. So the bioinformatician would be taking, probably 6 weeks to 2. The person that actually looks at all the genetic data, and they'd be taking too long to actually say, look, this patient's got a mutation here, there, and everywhere. And what we found was, what do we do with those patients that don't have any mutations? Because that occurs where there's absolutely nothing in the tumour that we can target. And then there's patients where the tumour is ultra-mutated, where you just wouldn't know where to start with that patient. So it's a really difficult area. We are persistent in that area, though. I do believe in it. I do believe that there's value to be added. And I think working with the clinicians in particular and actually showing the clinicians the roadmap of that tumour and saying, hey, they've got a mutation in this gene, it might be of interest to you, and actually just helping the clinicians guide them in their decision making, I think, is where the real purpose lies for precision medicine.
Yes, Kerrie and I shared an avatar patient where I think 20 mice were growing that particular patient's tumour, which was interesting, but I guess ultimately didn't necessarily affect our specific decisions.
Right.
Yeah.
So, in relation to trying to get in a mouse.
Just speak into the microphone.
I'm sorry. So, in relation to my question, which was about recruiting or getting into one of, getting tissue into one of your mice, is that something that can be happened? And given many of us have probably had some sequencing done as well, probably more recently than that, does that affect eligibility or your interest?
Oh no, absolutely. We're very interested in this program still. The issue is getting that fresh tissue.
Yeah.
Is as soon as it gets cryopreserved, we can't use it anymore. So what we need to do is collect it straight from the surgery, and so we've got that program up and running at Prince of Wales Hospital in particular that we can do that. So, and it's a prospective thing. So we need to capture you at the time of surgery. Yeah. So they're tricky bits.
So it would be changing surgeons and going into Prince of Wales as a extreme.
Let's maybe talk
we'll
offline about the specific challenges of that. But thank you very much.
So Kerrie, what is the time window between coming out of the patient and getting it to you? Is it a minute, an hour, 2 hours?
It's around about 15 minutes, I think, on average.
I think
we work together.
We've got another question
From
here.
the time it comes out, it's collected within about 15 minutes. And then a 10-minute walk down the road to the university to Kerrie's lab.
Okay. Question from the floor.
Thanks, Helen. Just a question on the cost of MRIs. Is there a reason why you can't claim on Medicare or from your private health insurance?
Okay, so those of us that order through the public hospital, it is rebatable. There are some surgeons. I mean, I guess perhaps if Jacob wants to or John wants to take that question. So it depends on where the surgeon usually sends the patient, I guess.
Fantastic question. Unfortunately, this speaks to Medicare funding arrangements with different types of MRIs. MRIs in public hospitals don't cost a cent. Unfortunately,
to the patient. To the system.
Correct. don't cost a cent to the person who actually has it done, the important one. Unfortunately, there are a lot of MRI machines. Some MRI machines get a Medicare rebate if the MRI is ordered by a GP, but not by a specialist. Paradoxically, some MRI machines have a Medicare rebate if the MRI is ordered by the specialist, and some attract no rebate at all. So in answer to your question, some machines, unfortunately, do cost in order to have an MRI on that particular machine, but if you have it done in the public hospital, it shouldn't cost the patient anything.
You've got to be super organised, though, if it's in the public hospital. Generally, I'm looking at an MRI and writing the next form because in our hospital, it's a 10-week, sometimes 10 to 12-week wait.
Unfortunately, that's the big problem, access. There's always a lag from the time the MRI is ordered to the availability of that resource in the public sector. So if you want a rapid MRI, unfortunately, it often has to be private.
But if finances are an issue and you want it done publicly, let the doctor who's ordering your MRIs know that so they can work around that.
Yeah, my surgeon can't use the MRIs that I'm providing from the public health hospitals.
Okay. Yeah, so yeah, I guess...
It's a very good question, and it's probably a conversation to have with your surgeon.
Yeah, definitely.
Right. And is stem cell research going on for the tumours?
Okay, stem cell research. So, Kerrie, do you want to take that first?
Okay, so stem cell research, it depends how you define stem cell research, because we all do stem cell research because that's the heart of the tumour. That's, basically when we take our tumour from the patient and grow it, we're actually growing the stem cells, and that's what we do. And we know that the stem cells are the most chemo-resistant and radio-resistant there is as well. So I think majority of researchers are working on stem cells right now, knowing that it's just such a huge topic.
Michael, do you want to just tell the group what a stem cell is?
Not really. I'm not quite sure that that's what the question was talking about. Because you hear about stem cell treatment where you take stem cells from somewhere else, like the bone marrow, and inject them into the person, and they repopulate the area of damaged tissue, say after a heart attack or something like that.
Yeah, but we don't do that.
That's not really in prime time for brain tumours. A stem cell, thanks Liz, is most of the cells in a brain tumour have divided, and they've differentiated into recognisable cells. You've also got a population that just keeps dividing and repopulates the tumour. And these are the ones that, they're not the majority of the tumour cells. They're actually difficult to identify, and you can't actually identify them easily by just looking down the microscope. But these are the ones that will, if you don't get rid of them, will repopulate and regrow the tumour. As Kerrie said, they're also chemo and radio resistant. So trying to find a way of making these cells sensitive to treatment is a very important research question.
Helen, did you want to add anything about that kind of research? No? Okay. So very, very specific question to Helen. Is chemotherapy recommended for grade 2 oligodendroglioma after resection?
It depends on how much has been resected. So if you've had what we think is pretty much a gross total resection, we may well sit back and watch. It depends on the location of the tumour. If it's in a really eloquent area, like if it grows back, you're going to become paralysed or not be able to talk, then we may well advise treatment at the time. It is also a bit dependent on the grade 3 oligodendrogliomas versus the grade 3 astrocytomas. We would recommend treatment if the patients are over 40 years of age, if they're having uncontrolled seizures, and usually then in those situations we found that giving chemo, radio or radio chemo sequentially doubles survival and doubles time for these things coming back. So there's a number of factors we take into account. If it was a 24-year-old guy that had been able to have a complete resection, what we think is a complete resection, we may well sit back, watch, and not necessarily recommend chemotherapy or radio at the time. But we now know one is not good enough. You can't, if you're going to have radiotherapy, you need chemotherapy as well.
So part of the long question about a particular patient with a grade 2 oligodendroglioma is why was that patient not given temozolomide at a certain period in time? So the high-level evidence in oligodendroglioma is not there, and it's actually not on the Medicare rebate for oligodendroglioma specifically. If you actually look at the description, it's for glioblastoma and anaplastic astrocytoma. It used to be, temozolomide used to be a lot more regulated. We had to ring up Canberra to sort of give quite a few details about the patient before we could get the temozolomide. The temozolomide is a little bit less regulated now. We don't have to necessarily ring up for each time, but it actually is still not on the books for oligodendroglioma, and that's a vexed issue. And because it's gone off patent, it's very expensive to get an indication with the Medicare for a drug, and because it's gone off patent and there are generic versions of temozolomide, there's not much incentive for Merck. It's Merck, isn't it? There's 5 different companies that make it, but there's very little incentive for the original company to put that request in for a new indication. So there are still some issues with oligodendrogloma. Helen raised up, are we ever going to get some good data comparing PCV with temozolomide? A few of us around the table are involved with an international study called CODEL, which hopefully will open in Australia for newly diagnosed grade 2 and grade 3 oligodendroglomas, doing just that finally, which will in fact be comparing radiation with temozolomide followed by temozolomide, which is the STUT protocol, versus radiation followed by PCV, which are these old drugs that Helen talked about, which is still in some ways the gold or sort of bronze standard. Very tough combination of drugs to get through, but it's a genuine question. We genuinely can't sort of put our hand on our heart and say that we think Temodal's better, because some of the retrospective studies don't show that. So we really do have to do the hard yakka of doing that study internationally. Because it's an uncommon tumour, we're working with America, Canada and Europe to do this particular study, and it probably, as Helen says, it'll read out after some of us retire. Okay, so we've got some questions from the audience. We'll, just in case. We'll hang on, wait. Lady in the blue jumper first.
With what Helen said about you have to have either one or the other, or both together, I should say, so a treatment of chemo with radiation for an OLI, with a patient being offered to have a PCV treatment post-resection and holding back radiation as a backup plan, do you see that as a good suggestion, I guess, as a board across all of you that are involved in looking at what the PCV alone does? What are your thoughts?
It may be fine. The guys in Canada that actually discovered what an oligodendroglioma was, which is the 1p19q genetic thing, give Temodal, full stop, no radiotherapy, and say anyone that gives PCV should be shot. The studies have never been done, and so we don't know what happened if you just had radiotherapy and didn't follow up with chemotherapy. We cannot rescue those patients when they recur by giving them chemotherapy 5-10 years out. So it may or may not be the same that if we just give chemotherapy and then things start to go pear-shaped, can we rescue the patients with radiotherapy at that time? It's unknown. And there's a lot of controversy, and a lot of us have very personal opinions about what we should do, but the gold evidence, the gold standard is PCV and radio, either first or second. And some people go by the recipe. So you can't criticise anyone that does what they think's right.
I'd be shot, I use it. Sue, any comments about that?
I would agree. I think it's for grade 3 tumour, having post-operative radiation is still standard in terms of treating the local, visible and invisible disease. I think I would personally feel remiss not recommending it for a patient that would benefit. The grade 2 group is a little bit more tricky. I still have reservations about, it's interesting, say 10 years ago we'd be just potentially doing surgery, and now we're actually shifting to giving 3 types of treatment: surgery, radiation and a very tough chemotherapy regimen. And I do have my reservations about even some of my younger, very fit patients completing all of that. It is really tough. So I think it comes down to just the expertise of the group of doctors really selecting the appropriate patient, because it really comes down to, and I just want to say a bit of a philosophical comment about, whilst the treatments are incredibly important and we understand why they're important, I just think we need to really balance it with the quality of life aspects and taking a break and just balancing things that one can control, such as diet and physical activity and time with family. And I've had incredible relief on my patient's face when I said they can go overseas for their holiday. It's just their dream holiday. And I just think keeping everything in perspective, the treatment and all the benefits, but balancing the side effects is a really important decision. I think that's a joint decision between, the medical, the nursing team with the patients and their families.
Yeah. I think most of us would agree with Sue that we work around the patients and what their desires are. So, a lot of our patients are travelling or on holidays, and we just fit in when they can fit us in. So there was a question over there. Just, Jonathan. Okay, all right. Alice? No, sorry. Pam.
With regards to Avastin for the VEGF, when you go down that path, is there a point in time when you're actually able to come off it, like you can do with chemotherapy, and then go back on it?
Not according to Roche, but they have a rule, 10 mg per kg every 2 weeks, or, we won't give it to you for free. It's pretty rare that you can come off it, and we also find that people's scans can look normal after having Avastin for relapsed glioma, but their functionality is hopeless because the tumour cells march one by one in Indian file throughout the brain. They're not detected on an MRI. And so we can have a patient that is absolutely fantastic, whose scan doesn't look so good, and a patient whose scan looks fantastic and they're terrible. We don't scan after Avastin in general, because if someone walks into my office and they're feeling fantastic, they've got no side effects, I'm not going to stop it no matter what the scan says. And if someone comes into my office and they look dreadful, I'm not doing them any good. So I will probably suggest that they stop. I have weaned patients, a couple of patients successfully off Avastin. We tend to first decrease the dose and then to gradually increase the duration between infusions, but it's relatively rare that you can get off it after you've started it.
Cogno, which is a group that all of us belong to, actually did a study looking at that exact question. So it was in recurrent glioblastomas, and basically patients either got Avastin alone or Avastin plus carboplatin, and then when the MRI got worse, the next question was half the patients were randomised to continuing the bevacizumab, and half of the patients, or the Avastin, and half the patients stopped. So the first bit of the puzzle was carboplatin doesn't add benefit to the Avastin. Unfortunately, we didn't get the budget to do another arm of chemotherapy alone. Both arms got the Avastin. But the next question was, does continuing bevacizumab or stopping it make a difference? The answer was slightly underpowered. We had slightly less patients going to that part 2 of the study than we thought, but it does not look like the patients who stopped the bevacizumab did any worse than the patients who continued it. So yes, I think people can come off it, even though I think our American colleagues are loath to stop it, and our drug company colleagues are loath for us to do so.
But Liz, that decision about stopping versus continuing was made when patients progressed.
Yes, that's right.
So, it's not like, can I just stop it, or can't, you're stopping it in the face of progression, the right thing to do or the wrong thing to do. It's not, can I never stop it?
Yeah.
I've heard that if you stop it, it gallops back.
It's galloping. You usually stop it because they're progressing. And so you've got to distinguish between something that's getting worse by itself versus stopping the Avastin. And we certainly don't see that. We see that they're sliding, we stop the drug, and they continue to slide.
Okay, so you wouldn't recommend continuing MRIs then? Like, my daughter's got a grade 4 glioma with features of glioblastoma from her last pathology, and she started Avastin. She's coming up for her 10th infusion. Now, clinically looking at her, as I look at you, she looks fine. And but she says to me, how long have we got to stay on it? I said, I'll find out for you. So, because there are different schools of thoughts, and I belong to a lot of support groups, and as soon as they hear the word Avastin, it's, oh no. They're not encouraged by it in any way. Like, there doesn't seem to be anything positive about it. So I don't know if that can be rectified or not, to give patients, or to continue patients having that hope that it's going to do some good.
I think the first thing we need to decide is who started and when. So sometimes people will start it for quite soon after the radiotherapy is finished. And if we have someone that's really swollen after a radiotherapy, we sneak in 1 dose of Avastin, settle them all down and just get on with what we're doing and never give them again. And it's dramatic and it's fantastic. So you need to look at the timing. Why was it started? When was it started? And if she's very, very stable, the more you're on it, the longer you're on it, the more side effects you get and the more fatigue you get. So if I had someone 1,000 milligrams and they look like they were fantastic, like your daughter sounds, I'd probably give them 800 for a couple of goes. And if there hasn't been a problem, I'd probably give them 600 and not tell Roche, and gradually wean it down. So but you have to, every doctor's different.
Yeah.
So the reason why Avastin's not on the PBS is because none of the big studies have shown a statistically significant survival benefit, and that's kind of the bar it needs to go. But we know in neuro-oncology that it's a very useful drug, but it has its place and not necessarily upfront, except for that situation that Helen mentions when there's swelling after sort of radiation. So it definitely has its place. So another thing for your list, Pat, of advocacy that we probably do need to get it available, because it is very useful in the right patient, but there are some unanswered questions. So I think there's still another question over there.
Yeah, Helen, Dr. Hovey. It's regarding my question that I had earlier.
Okay, keep it specific and no specific doctors, please.
No, okay. Regarding the chemotherapy drug, Temodal. You mentioned it as banned for grade 2 oligodendrogliomas.
It's not banned, it's just not reimbursed.
Okay. In that case, if it's exhibited good results in the past, as it has in our case, and chemotherapy with PCV fails, is there any recourse to getting Temodal, access to Temodal, to have some benefit instead of going and having surgery again?
Look, certainly if someone has stopped Temodal because they've finished a course but they never progressed on it, you could certainly speak to your doctors to see if Temodal could be offered again. And also, second opinions are really, really valid as well. So if you get an answer that you're confused about, all of us have got thick skins. So, Helen and I have both seen many patients, and I'm sure the same with surgeons and so forth. We understand this is a really important moment for a patient and their family, and people want the very best. So if you want to get more than one opinion, that's a very valid thing to do, and never be shy about asking for your letters and correspondence so you can get those sort of other opinions. But if a patient's done well on temozolomide, certainly there's a possibility of going back to it. Okay, I might go back to these prepared questions. So this, is there another one from the audience? Yep.
What is the difference, or what? How big a difference is there from a grade 3 to a grade 4?
So, Michael, why don't you start with that one?
Well, talking about astrocytomas, a grade 3 is an anaplastic astrocytoma and a grade 4 is a glioblastoma. From the pathological point of view, they look different down the microscope. Well, from radiologically, they look different. Pathologically, they look different. And they've got a different prognosis in terms of overall survival and progression-free survival. And they're also treated differently.
They're treated more similarly now because of Catnon, which was a study in the grade 3s, which definitely showed that temozolomide after
but sequential rather than...
Sequential, but we're still waiting on the concurrent results. And so many of us are using it concurrently, even though don't tell Medicare. So it is getting sort of more similar, but we don't yet know the high level of evidence for the concurrent.
And certainly, depending on the genetic kind of tumour, the genetics can also influence what a grade 3 really means. So not all grade 3 astrocytomas are the same. Similarly, not all glioblastoma grade 4 tumours are the same. So if it's got an IDH mutation, it's got a better prognosis and overall survival than if it doesn't. So does that sort of answer your question? Or?
So some of us, if we see a grade 3 that isn't exactly as Michael says, and Michael will be in our meeting saying it's not IDH mutated, we'll err on the side of treating that patient more like a grade 4 tumour.
There can be also a discrepancy with the pathology report versus what the surgeon sees or the radiologist sees, because one of the images that Jacob showed was this ring-enhancing lesion, which was almost certainly a glioblastoma. Now, if the surgeon only gives us a bit from the edge of the tumour, we may not have the features that allow us to call it a glioblastoma. So the difference between a grade 3 and a grade 4 is based on the pathological difference is largely based on the morphology under the microscope. So a grade 4 has areas of necrosis, dead tissue, and areas where you've got blood vessel proliferation. Now those changes are focal. They're not scattered evenly throughout the tumour. So if we just get a small bit of tissue and it doesn't include those particular features, we can't call it a glioblastoma, a grade 4 tumour, even though radiologically it may be typically a grade 4. So in that situation, we'll say that maybe the biopsy is not representative of the entire lesion, and usually the clinicians will treat it as a grade 4 tumour.
And Sue, does a radiation oncologist distinguish between grade 3 and grade 4? I know you distinguish between grade 2 and grade 3 and 4, so do you want to just...
So in terms of radiation dose and the contouring that I showed you in terms of coverage of the visible and invisible disease, it's quite similar. I guess the only caveat that I didn't mention is that for a younger, fitter patient, we would recommend the 6-week course of radiation, so 30 treatments, so 5 days a week times 6. There is now evidence from international studies that for a slightly older patient, be it 65 plus or 70 plus, who is still fit enough, a more condensed 3-week course of radiation is as good as 6 weeks and spares the patient the time and commitment for the extra treatment with, and that can still be given with the temidol chemotherapy.
Okay, I'm getting to the controversial questions now. So, this used to be a lot more famous a few years ago, but what is the panel's view on the Dr. John Holt method of using radio waves, heat and hypothermia to kill cancer cells? So does anyone want to start with that? Anyone reaching for that microphone? Jonathan at the back, any comments?
I think we've got lots of experts at the front of the room who can speak to this question.
So we'll start
My
with
general
Helen.
comment is if something has been around for 30 years, they have probably treated 500 or 600 or 700 patients. Where the dickens is the paper telling us how it works and on whom? And that, to me, if it's so fantastic, why are you holding back? We'll buy the machine for Sydney and we'll do it to everybody.
So there was actually an okay, Michael's got something to say.
I'm going to interrupt. If something sounds too good to be true, it often is. And unfortunately, there are a lot of vultures in the cancer game who will try to swoop to separate patients and family from their money.
I asked that question. My son did go over to Perth and had the 3 weeks treatment. What the big change was that he didn't have any seizures, which was a remarkable difference because he was having regular seizures.
Did he have the microwaves or the hypothermia? Do you remember what your son had?
It's some time ago,
Right.
and so unfortunately he did die because he had GBM. But I think that there wasn't. My understanding was that there wasn't enough written data to base research on. The clinic has been closed down and gone to Holland, as far as I understand. I do not understand why it hasn't. That if this method did have some legs on it, and it was not just that a lot of people had a similar experience with their patients, that they did have certainly symptom reductions, and maybe with more work in that area, they could have had a better outcome.
Look, it's an excellent question. We have a radiation oncologist at Prince of Wales who is interested in hypothermia, and has an open mind about it, and has been running sort of on an ad hoc basis, but hasn't done a prospective trial because there hasn't been the budget. I can't remember. It was probably about 8 or 9 years ago. Sorry, back. Hang on. I think we're being. Okay. It's not. You need a budget for devices as well as for drugs as well. So it is unfortunately incredibly expensive to run a trial. There was actually an inquiry into to the high voltage approach, and I think there was an MSAP. There was actually a big document, hundreds of pages that came out. with their concerns, and there was a very strong recommendation against going down that path at the time. I don't know if you remember any of that's probably just a bit before your time, I think. So.
Having said that, there is evidence that tumour treatment fields, which has been used, what's the
NovoCure, TTF, tumour treating fields, which sounds very unusual.
Which everybody sort of poo-pooed and said, "Oh, don't be silly, that doesn't work." It actually does seem to work in some cases, and there have been studies that have been published in peer-reviewed journals that says that it does have some effects in some people with glioblastoma. It's very expensive, and I don't believe it's available in this country yet.
Definitely above $100,000. I think well over that. I think it's close to $1 million for. Is it? I think.
But it does have an effect.
Yeah.
It doesn't cure the tumour, but it does appear to have an effect.
So for that, I think patients' hair is shaved. They get little sort of spots put on their head that they've got to put on. They've got to wear 22 hours out of 24 hours a day, and they have the machine in a backpack that they wear. Yeah. And it does show, and it basically flip-flops the electric fields, and it does actually show, and Roger Stupp, who's as of the Stupp protocol, has been involved in the studies, and Michael's right, and I'm glad you brought it up. It does look as though it's positive, but it's currently not available in Australia. I think the company doesn't think we've got a big enough market, which I guess is a good thing in some ways, but it's... so if people want to pursue it, I think they need to hop on a plane. I don't know if Helen, if have any of your patients gone overseas for that?
I had 2 patients that went to Switzerland for it, and they could bring it back and they'd post them batteries. So it didn't work.
When I was in the States, I saw a bloke in the airport with the thing on. So I wonder how he got through security with all that stuff wired to his head, but he did.
I mean, I guess it's something you wouldn't forget you've got a brain tumour. I mean, as you said, your daughter looks normal. You certainly would be very aware that you've got a brain tumour 24/7, if not 24/7. And those 2 hours, I imagine, while you're in the shower or sleeping.
Liz, can I just add? I guess my view is a little contrary to some of what's been said, and I think we understand as a health community, we understand where the motivation comes from to try different treatments, and I'm open-minded. I guess for my patients, I don't want them to be ripped off financially. And as Jacob said, there are the extreme charlatans, but I think there is scope for cure and support, and maybe the answer will come from something very left of field. And most of us are conventionally trained, and we're actually very narrow in our thinking, and that's because we are not trained in a complementary or alternative medicine therapy. So what I would just encourage is that you would disclose to your clinicians what you're contemplating, and we will openly say, look, we have no experience with that drug or therapy, but there are some things that we do have evidence for interaction with standard chemotherapy or radiation that may actually inhibit or limit the benefits of those treatments. And I think so the disclosure is important. We understand the motivation, and we will advise as best as we can. But I personally wouldn't dismiss something outright, but it's just that the rigour and the evidence level that we put on something is different from other practitioners that come from a complementary background or training. So I think we just need to, for myself, I keep an open mind about it, and I appreciate the honesty of patients and families to disclose that to us.
And some of our best drugs in medicine come from plants. So I think many of us are open-minded, but as Helen said, the rigour of evidence is really important, and we all were trained under the algorithm of evidence-based medicine. This next question relates very much to what Siou's just been saying. Are herbal treatments to boost immunity good for people with tumours? Can they contribute to the tumour changing its behaviour, e.g. becoming more aggressive or change from benign to cancerous? So, Helen, do you want to start with that one?
I thought I made it pretty clear in my talk. I mean, there are good immune cells which will attack and destroy cancer, and we've seen this time and time again in cancers like melanoma, lung cancer, etc., etc. And there are bad immune cells which will sit there and be a brick wall, castle wall, can't get in and protect the cancers like no tomorrow. Now, the problem is we don't know what's what, because whenever someone discusses complementary medicine that's been, cost them $20,000 a month, and they say this is to boost my immunity, and I ask them which part, the conversation stops. So who knows? The problem is we just don't know. And of course, anyone sitting in this room wants things to be better. We want to get hold of new drugs, new treatments. And if I say to someone, wow, I can cure your cancer, I have a file out the door that takes months to get through. I think it's just making sure that we protect our patients against false hope. But also, I'm pretty open-minded. The first thing I did in glioma was give patients thalidomide back in the 90s if there's a repurposed drug, because there was a hint back in the 90s that it might help. But we did that as a formal clinical trial. We wrote it up in a journal. We published it for the world to see. And so if someone in America wanted to try it again, they would know what had happened. And to me, it's very important. If there is a treatment, it seems to have worked, and you've got 100 patients and 50 of those patients' GBMs have gone away, well, why not share the information? Because we would do it here tomorrow. But keeping it as a secret and being able to sell a story for enormous amounts of money, to me, is very, very wrong.
While you're puffing on that question, Helen, any comments about cannabis?
If you take enough of it in, when it became very popular just a couple of years ago, the patients were so stoned they couldn't find the door in and out of my office. But anyway, open-minded, very open-minded. So there's about over 490 different chemicals in cannabis, and it depends on which seeds you are growing as to what components are emphasised. One component, something called cannabidiol, is being bottled in almost pure form and being used to treat seizures in the kids that have called Dravet syndrome and Lennox-Gastaut syndrome. And about 50% of those kids, where nothing else has worked, the cannabis, not only the Epidiolex, which is now marketed under, is helping the seizures enormously. They come off a lot of drugs, but not only that, their behaviour changes and their cognition improves. So it's certainly in that group of patients. It is being tried in adults with common garden variety or brain tumour seizures, and the door's still open about that. In a rat study, if you give 50% THC, which is the stuff that makes you high, and 50% cannabidiol, and treat certain rats with exactly the same tumour in their heads, in combination with Temidol, there is some extra response when you add the cannabinoids in. And there's been an early trial which was pretty dodgy to suggest that there may be some clinical efficacy. So if we're going to do a proper trial, we need to know what we're giving them, what proportion of X, Y and Z is in it, and to evaluate the patients like we do anything else. But I wouldn't dismiss it.
And Kerrie, just in terms of alternatives, do you ever look at alternative drugs or herbs as sort of candidate sort of products?
Look, if they've got a good rationale for it, we'll test it. In my experience, the good rationale hasn't worked out in the lab, and we've canned those projects pretty early on, but I'm still open-minded, and if someone comes to me with a good rationale, we'll test it.